We are now going to switch gears into another part, but we're moving under 65 for a second to talk about short-term medical.
Okay. So short-term medical is kind of these like not on the ACA marketplace plans. And oftentimes they're kind of catering to a similar group, like this non-group, younger, under 65 population. They're cheaper because they don't have all of the requirements. There aren't subsidies. So who ends up on these plans are usually healthier people, people who don't qualify for subsidies. So think above 400% of the federal poverty line. So all the stuff that we mentioned with the marketplace shift earlier, that's really important here, because if people are losing their subsidies, it might become much more attractive to move to a short-term medical plan, right? So thinking about both of those markets together as substitutes is going to be important. In the previous Trump administration, short-term medical had a bigger kind of market in terms of what they could do. Currently, it's limited to plans of 3-month duration. So you leave one employer, you go to the next, you kind of have this stopgap plan. But now it could go back to where it was in the 2018 rules, where these plans can be up to 12 months for a plan period, and then they could re-enroll for up to 3 years. So this has opportunities. Some people are clamping.
Yes, we need it.
But it'll be interesting, right? Options for consumers are important. At the same time, options are more complicated for everyone involved. So those brokers become really important here too.
This has been like one of the most roller coaster, I think, pieces of legislation over the last 7-8 years. It's you have to kind of just check yourself. Okay, what short-term, major medical? What's the rules right now? But it's needed. I mean, this is definitely something that I hope we push and fight for. 3 months is not long enough sometimes for, a break in plans or, before you're getting the next job offer, before you, get moved to get settled, whatever's going on in your, situation. But we need a longer duration, and then being able to renew up to 3 years. You're, 62 waiting to get onto Medicare, whatever that looks like. There are plans there that, that work for you, and we need this for sure as an industry, I believe.
I mean, I would obviously support it, even though we don't really deal in it. But no, I agree. I think it's especially like to the 62-year-olds, kind of that gap between 62, 65. And I think it's important for that population as they're kind of waiting to get into the Medicare Advantage world or Medicare world. And I think it's important for them.
This is not quite related, but I think it's also important to think about that early retiree population of maybe it's a good idea to get on the marketplace and repress your income, through retirement contributions, withdrawing fewer resources, and get those subsidies. I think that's important too, just because those older patients might have more medical needs. And so being on one of these plans versus the marketplace plan, that's a complicated thing. But if brokers aren't really thinking of income necessarily being fixed, but something, especially an early retiree, can manipulate, there could be opportunities there too, but complicated.
So this might be a little bit out of left field, but last night someone was having a conversation with me about this topic and suggested that they thought there was a possibility that a move that might be made is lowering the MA age or the Medicare age in general. Are any of you hearing that that's a possibility of going even as low as 55, maybe connecting it with some other eligibilities to bridge those older members or those older lives who don't want to go on the exchange but are no longer necessarily working or covered by work?
I have actually heard that. I don't think
it was not.
I don't think no. I don't think that's going to be the solution. I would find it difficult. I've heard of it. I think it's one of the rumor mills that are swirling right now. But I mean, that would be the opposite of kind of what the administration was shooting for. So I don't see that happening.
Fair enough.
Yeah, if we're thinking about like the trust fund solvency issue, putting more people onto Medicare is going to be more expensive, and that's going to be a major challenge.
And we have one more topic that we want to cover, and this is This is something that we've been hearing around the industry. This is a little bit deeper than we have time to go into, so we're just going to kind of address it as at a top level. But it's generally the overall move into value-based care and how that really just affects so many different parts of this business.
Yeah, so CMS has been playing around with payment models for a long time and multiple iterations, and so that's going to continue, especially if the new administration, Dr. Oz, are really concerned about efficiency, and kind of one of the strengths of the MA program really has been not that fee-for-service, pay-as-you-go, doctors make more money if the patient is sicker type model. And so while there has been these programs in traditional Medicare for a while, right, are those going to scale up? And does that kind of lead to more group and value-based payments? Another thing slightly related to kind of the inner workings of the insurance side is thinking about like prior authorization. There's been some broader policy, bipartisan policy pushes to kind of improve transparency there. And that has very different implications for traditional Medicare versus Medicare Advantage too, since the Medicare Advantage plans tend to use more prior authorization. But then if you have a value-based group, right, what does that do to that need? Can they kind of bypass that more because it's a bundled payment model? Those are definitely open questions going forward.
Yeah, I think I referenced value-based care earlier. So we have about 50% of our population in the value-based care model right now. That is one of our strategies when we look at the Georgia market. The Georgia market is not like a Florida market that was more mature in value-based care, so there's a little more junior. But I think you talk about, you mentioned the prior authorizations. If we have someone who is managing the members, then they can have a complete open access panel. We're going to trust that physician to make the right decision because he's only going to benefit if the person stays healthy and stays out of the hospital. So it really is a win for all parties, the member, the insurance plan, the physician, and even the brokers. In Florida, I was in Florida 20 years prior to moving to the Georgia market. If you had groups, large groups, you would not walk into an office without seeing 2 or 3 broker tables set up. And it's an opportunity to sell, especially if they're associated with plans that have like the chronic conditions and they can sell those year round. So it really does benefit, I would say, all 4 of those parties.
Yeah, and just from us from the distribution side, I think about why would you sell like carrier A over carrier B, and I think that's an important model. We love provider marketing. We love our partnerships that we have with different groups around the country, and it's important for brokers to understand the model, right? It's important for brokers to understand where you're putting your client, making sure they're taken care of, with that physician's group or, doctor's group, that it's important. So that's kind of just from the distribution side what we have.
Well, and I think the other thing that we see the benefit from these groups is just around the social determinants of health. They do so much. They'll host lunches every day. So if someone can't afford to eat, they just get a ride, and usually they provide transportation if the MA plan doesn't. But they will do lunches. They do, dancing classes to keep people out of the house and not isolated. So that's a huge benefit to this model also.
I think too, thinking about the broker piece, like how well that is communicated to the brokers and then to their clients, I think that's important, right? And then if we're thinking about churn, which has been a criticism of MA plans, can more of these bundled payments and groups of providers kind of reduce some of that because they want to stay with that group of doctors where they have a relationship?
Yeah, I would definitely say that's absolutely true. I mean, we are, again, 50% of our population, and our disenrollment rate is only 2.5%, so it's very low. But that is directly correlated to the relationship that these groups have. They're very engaging with those members.